We'll start with our first presentation by Professor Till from Graz in Austria on the laparoscopic sleeve gastrectomy in morbidity obese adolescents. Holger, please have the word.
First of all, of course, I would like to echo the thanks, especially to you, Ciro, for inviting us to this beautiful city and to your wonderful university again. It's a pleasure to be here, and it's also a pleasure to be amongst friends and pioneers from both societies. I'll start with my first talk. I think this talk is a little bit extraordinary to most of us in the community of pediatric surgery because most of us are trained as neonatal surgeons, as GI or thoracic surgeons, urology as well, but not on metabolic surgery with obese. But we should. I think there is a pandemic problem coming our way, and we should not, for numerous reasons, leave these problems to adult surgeons who are not equally educated as we are in terms of morbid obesity in childhood. So I'll take you through a different agenda. I'll first of all will outline the problem. Do we have a problem with morbid obesity in children, yes or no? To make the community aware of this. Then I'll define the real problem, the disease of the metabolic syndrome, come through some international guidelines, and then finally I will end up with my favorite operation, the laparoscopic sleeve gastrectomy. Please note already the lower graph, the simple one here, which basically shows that childhood obesity is increasing globally. While we had overweight, defined as a BMI less than 30 and 25 in 2000 of 12% and obese patients of 4.6 in 2025, that's the forecast of pediatric obesity just recently in 2016, we'll have 15% of our children being overweight and 5% being obese. And you can have all of these different graphs in the internet basically showing that it is a global problem indeed, and it is a growing problem indeed as well. So it's worldwide and it's increasing over the next years. We have to face it. What is actually the problem of these children or adolescents? Are they just big? No, they are sick. They are severely sick. Just like adults, you see some of the metabolic diseases that we used not to see. Remember medical school, when we all went there, we noticed that there is no type 2 diabetes in childhood. It's always the type 1. Today, the incidence of type 2 diabetes in children is higher than the one of type 1. More children have a metabolic syndrome and a peripheral insulin resistance then they have a pancreas insufficiency, which is the type 1. And of course they have insulin resistance in some organs like the muscles and the liver. They have dyslipidemia, fatty liver tissue, PCO syndrome, polycystic ovarian syndrome in females, endothelial dysfunction. The vessels are getting bad already at that age, and of course chronic inflammation. If you see some obese patients for a suspected appendicitis, please note the reactive protein can be high just because of obesity, not of the inflammation. And that all is called the so-called metabolic syndrome. Why am I stressing this? The target, the aim of the surgeon is not to make the big child happy and beautiful. No, it's to cope with these diseases. How do we treat those patients? Of course, not like Dr. Jukes in this historical thing, like pumping up the stomach, but this graph shall show you this is not a new problem we are facing in mankind. Whenever there is too much food available, we have these problems. Let's come back to reality, success or failure. Kelly just published in Circulation a well-known paper in 2013. Basically, there are no drugs available for childhood obesity and adolescence which provide a long-term success. Yes, pharmacotherapy is available, but even the best studies show that it provides only limited weight loss over a short period of time and weight regain. Even the best lifestyle intervention programs worldwide have limited weight loss, achieve about 10% of weight reduction, Let's figure this out. If a child is 130 kilogram, and if you 10% weight reduction after 1 year of hard work and lifestyle program, it still weighs about 117, and there is no way that the metabolic diseases have disappeared. Early rebound, even less in the super obese patients. In summary, stated in Circulation 2013, most conventional interventions show no effect on those diseases which I described before. So what else? Well, after certain guidelines, you have to consider surgery in these patients. The justification for doing surgery always is a risk and a benefit study. And the interdisciplinary European guidelines have clearly shown that there is a pro for the morbid obese adolescents. And the following inclusion criteria are state-of-the-art at the moment. If an adolescent has a BMI of more than 40 and one minor comorbidities, the ones I showed before, dyslipidemia, PCO, and many other things, then this may be a reason for the operation. Or a BMI of 35 and a major comorbidity, like diabetes. More steps to come, and criteria to include failure of a professional lifestyle intervention program. So they had all of them, which may be considered for surgery, had to go through one of these lifestyle intervention programs, plus or minus pharmacotherapy. Skeletal and psychological maturity. You need to talk to these patients afterwards, because this is when the hard work starts. Surgery alone will not lose weight for these patients. It's the diet post-operatively. Psychological assessment, this is very important to exclude addictions, and then a commitment of these patients. Now the stage is set for surgery. I'll just take you briefly through the 3 different principles of surgery. The first one is well known to most of us in the community, and that is gastric banding. The basic principle is that you take a device, put it around the stomach at the junction between the esophagus and the stomach. Thus you create a pre-stomach, somehow occluded from the rest of the stomach, and this pre-stomach will be filled with food, and then some food will be allowed to go through. It is a so-called adjustable gastric banding because there's a pumping chamber behind here where you can inflate or deflate this balloon. The next gold standard technique, it's been around for a long, long time, is the so-called Roux-en-Y gastric bypass. You again create a pre-stomach and you disconnect it from the rest of the stomach. So the food goes a different way. It goes from the pre-stomach into a jejunal or a small bowel limb, which has been hooked up to this pre-stomach. Now the stomach remains connected to the duodenum. So all the elements and the enzymes from the pancreas or the liver are still diverted into the duodenum, but they meet much later the food. So this is the so-called alimentary sling, this is the digestive sling, and only later, down here, they are reconnected, and then the patient absorbs the meal and the calories. The third technique I'm supposed to talk about is the so-called sleeve gastrectomy. I'll spend some time on that, but the basic principle, again, is to resect the stomach longitudinal, remove the rest of the remaining stomach, and thus have a small pouch of 150 or 120 milliliters only. Which is the best procedure? We'll answer this in a couple of minutes. Let me explain the sleeve gastrectomy in detail. It is an old technique in the adult obesity surgery part, where it has been initially established in these super obese patients where you didn't or couldn't want to do the Roux-en-Y gastric bypass, but you just did the resection of the stomach. After these operations, the surgeons noted that these patients lost a lot of weight, and finally they decided, well, why can it be a standalone technique only? Thus it gained increasing popularity due to its success, and it has a certain, maybe applicable advantages for adolescents and children as well. It does not necessitate any foreign body. It's all natural. The gastric banding's disadvantage is that it basically has no major impact on the metabolic syndrome and on the metabolic circuses, where the gut talks to the brain. But like the gastric bypass, the sleeve does. So for these reasons, we introduced this technique in 2008, and we're one of the first group to work with this technique as a so-called standalone technique for morbid obesity in childhood. You'll see a video in a minute, and I'll prepare you for that. You have 5 or 6 trocars. The first trocar always is a handspan below the umbilicus. You need certain trocars, like a 50 millimeter trocar for the endo-GIA when you resect the antrum, and another 50 millimeter when you go all the way up to the crura and the junction. This video starts exactly where you skeletize the greater curvature. So here's the stomach, there's the spleen, there's the GI junction, not yet inside, and all you do is just mobilize the greater curvature all the way up to the short gastrics, which come here into sight. This is the spleen, of course. These are the short gastric vessels. And please note that you take great care to mobilize the stomach all the way to the left cruise, and to mobilize the posterior part, because this is what you resect. Don't leave it attached. The next movement then is to protect the lesser curvature, the smaller curvature here. You can either take an endoscope or a bougie, and now you're ready for the resection. You need to leave about 6 or 7 centimeters of the antrum, because the antrum, remember, is the motor for the pyloric region to open. And then all you do is shoot the GI all the way up to the GE junction. There are lots of discussions about these techniques, how to make it safer or faster. Of course, you change the GI cartridges along the way, because the stomach around the antrum is much thicker than at the His angle of His. There's much discussion how to secure these long stapler lines, because they are dangerous. One leak and it's going to be a disaster. So different hemotissue tissues are available, or you can just run a suture along the way. And then you disconnect the stomach. Please remember that this part of the stomach is the stomach that contains ghrelin cells that produce hunger hormones, and this part of the stomach is then removed completely. And the patient is left with this 120, 150 ml stomach. What are the effects? I mentioned earlier that the aim of the surgery is not to make the patient slim and happy, but to reduce the metabolic syndrome. This vicious cycle is the one that all these patients face. They go on a diet to reduce weight. The hormone levels, the body adapts to that. The body knows for thousands of years how to cope with hunger. So the hormone levels adjusts and adapt. The body just waits for the food to come back. And in the moment that it comes back, you have increased appetite, slowing metabolism will certainly make the most out of this food that you eat. And at the end of the day, we all know about this and can read about it, this yo-yo effect, you weight gain again. Bariatric surgery is just a chance. It's a chance to break out of this vicious circle, because the hormone levels, especially in the room by gastric bypass, cannot adjust to weight loss anymore, but the gut-brain axis is altered. Thus, you may have patients able sustainable weight loss. For many years, we've been trying to justify this technique and trying to justify, can we do it? The room by gastric bypass, especially Tom Inch from the US and Mac Harmon and all these people who have been doing the room by gastric bypass, argued that we don't have long-term data about the sleeve. That's true. But interestingly, Tom and I, we talked, and he changed. At least he adopted part of his patients to the sleeve gastrectomy, and now we're very happy that his group, a huge group, has one of the best articles published in this area, which I consider state-of-the-art. So what is he saying about the sleeve gastrectomy, the room by gastric bypass, and all the efficacy? I'll take you through that. Just recently in the New England Journal of Medicine published. The age group is typical, 13 to 15, 16, 17, 18, and 19 years patients, These are all of his patients, 228, and he has about 161 gastric bypasses and already 67 sleeves in that. So the demographics are about the same. How are these patients doing? In terms of weight loss, again, all patients, gastric bypass, sleeve. The weight loss of the Roux-en-Y gastric bypass patients is about as dramatic, long-term, 3 years as it is for the sleeves. So the percent change after 3 years post these operations for both procedures is about the same. Shown in this graph similarly. Of course, a careful look at this end of the graph shows that there is some regain, but there is always regain. And this is why the hard work has to continue with these patients. Sleeve and bypass always show the same pattern of a dramatic weight loss within the first year. Then some patients drop out, as you can see in the numbers of patients. Those who are clearly motivated stay in the program for 2 years, 3 years, and of course we need 5 and 10 years data on these things. But the good news is, again, in these patients, sleeve or bypass do their work in terms of weight change. What's the price you pay for it? Well, of course, these severe operations have severe problems. If you measure them by the Clavier and Dindo classifications and only look at the reoperations, you will see that here for 161 patients, he had 38 events. Most of them were endoscopic procedures. So he checked the anastomosis, he dilated the anastomosis, and checked the upper gastrointestinal tract. Similarly to the sleeves, in 67 patients, 9 events totally, no death, some reoperations. Similar results. The real goal I mentioned are the comorbidities. So how are these procedures doing? If you just take a look at the prevalence of dyslipidemia in these patients, 80% of these patients had them preoperatively, and then similar to the weight loss, you see that the bypass and the sleeve are both efficient, the bypass a little bit more. And this shows in this detailed graph as well, 3 years after the operation, if you took at the diabetes, pre-diabetes, elevated blood pressure, you will see the efficacy of both procedures. Before I close, I'll take you through one very interesting question, and that, of course, is, yes, they work, but how? Which pathways can we tackle, maybe someday medically, that have the same effect as the brutal surgery? Well, uric acid in our community is one of those. Uric acid contributes to metabolic comorbidities like hypertension and peripheral insulin resistance, and Tom Inch and I, we put together 5 of our sleeves and 5 of his Roux-en-Y gastric bypass. Yes, a small study, but we saw a dramatic difference in elevation in these uric acid and final drop in these uric acid levels. So uric acid may be one of the mediators taking place, telling the body to lose weight and perform. Since diabetes and pre-diabetes is one of the most fascinating problems in the context of the metabolic syndrome, we took the look at who is responsible for the metabolic profiling of these patients, and PEDF is one of these substances. When you inject it into mice, it leads to a reduced insulin sensitivity, and again, PEDF may be one of the factors that communicates between the gut and the brain for this weight loss. But we're still looking for the key factors in that business to maybe make it, as I mentioned, one day the matter of medical therapy. And with this, ladies and gentlemen, I took your time and took you into a world of morbid obesity, and I may conclude with the following statements. You and I, we are facing a global risk of childhood morbid obesity. If we want to or not, we have to face it as doctors in the pediatric field. Whatever we do must follow international guidelines, therapy as well as surgery. The perfect surgical age when to operate has not been validated yet, but I'm strongly stressing adolescence and not before that. The sleeve gastrectomy our favorite technique and the Roux-en-Y gastric bypass seem to achieve similar medical results, though I accept that the bypass is more efficient. At the end of the day, these both techniques result in weight loss and improvement of those comorbidities, and I strongly recommend that we as a pediatric surgical community stay on this topic and explore it academically. With this, I thank you, and I'd be happy for any comments in the internet. Thank you very much.
Okay, any questions that came in through our experts?
Yeah, there are some questions for Holger Thiel. Elizabeth Midden from Ireland asked, are there any difference in terms of weight regain after surgery between patients who underwent sleeve gastrectomy and gastric bypass?
Well, the advantage of the Roux-en-Y gastric bypass is that it's very efficient. Weight gain within the first year of life, as I showed, is very limited. The advantage of the sleeve is that people are doing faster, better. And again, depending on the postoperative therapy, there's some weight gain. But that very much depends on the diet you take afterwards. It's not the surgery, it's the program afterwards.
Thank you. One more question from Kansas City, Taylor Johnson. Which are the principal factors influencing timing for surgery in adolescent patients?
Okay, I saw that one coming. Let me put it this way. The major centers and the New England Journal states adolescence. I don't think that people should operate children, even though I understand that in some areas, especially the Middle East, some of the pioneers do. So my answer is adolescents with skeletal, social maturity, commitment to the program, because these are the people that we want to work with. We in Europe would not consider children.
Thank you. Sorry.
Can I ask a question? What about the outcome? Because usually it's about two standard deviations that you get a decrease in weight. But if you are a morbidity of 45 or 50, you can only reduce it up to maybe 35, and you're still obese, still have the diabetes.
Yeah, very good question, David. Thank you. First of all, again, the detailed data from the New England Journal study show you a weight loss of more than 40 kilo. And in the community it is well known that any weight drop of 10 kilo will have a beneficial effect on the comorbidities. So if you have hypertension, 10 kilos, you're doing better. Another 10 kilos, you're even doing better. So I'm aiming for the effect on the metabolic diseases. And with 30 kilo, you do fine. In terms of you get healthier.
Okay. Holger,
yeah.
One more question from Alexander Müller, Germany. What about the resolution rate of comorbidities after sleeve gastrectomy? Are there any difference between adolescents and adults?
Good question again. I think I went detailedly through the New England Journal in adolescents from Tom Inch, and basically you can have the same effect as in adults. Thanks for the question. The same beneficial effects in adolescents as in adults. Just name the SOS study from the Swedish population with data over 15 years. Thank you.
Doing these procedures, setting up your department with these procedures. I saw a very nice video. Can I start tomorrow?
Definitely not. No. This is one of the most. I guess this is the most important questions. No. First of all, the preoperative phase is extremely long. You need to get in touch with your pediatric endocrinologist and pediatricians. It's the pediatrics that should run the department of endocrine metabolic diseases. Secondly, this surgery is extremely dangerous. Once the sleeve leaks in a 125 kilo patient, you have a severe problem. So you have to couple with the adult surgeons, with an adult program that has a frequency of about 100 to 150 patients per year. Only then, if you have these two friends, you then have an interdisciplinary group that should tackle these problems. Thank you.
Can I ask you, Olga, please, a technical question? Do you need particular instruments, trocar, forceps instrument to do this surgery, to perform?
Long instruments.
Long? Okay.
Long? No, I'm serious. Serious.
Yeah.
You need long instruments. If you're not familiar with morbid obesity, the first trocar is a problem because we as pediatric surgeons are used to put the trocars into 3 kilo baby and not 100 kilo patients. So the first trocar may be a visional port where you just take a 0-degree optic and then plug it in under vision. And port placement is different to what you're used to. So the rest is standard. Long laparoscopic instruments. And then finally, the two technical details I mentioned is, first of all, protect the lesser curvatures so that the GIA doesn't harm it. And secondly, like any gastric surgery, the size of the GIAs must vary with the thickness of the stomach. Thank you.
Some more questions. Simon asked, when do you suggest to start post-bariatric surgery for this kind of patients?
Like I mentioned, adolescents. Thank you, Simon.
Yeah, there is one more question from Dennis Jansen from Netherlands. Is there a high weight loss in patients with previously intragastric balloon surgery?
With balloons?
Yeah, balloon.
Aye, clever. Well, the balloons, you know, they come and go, and they certainly have a very interesting scope. First of all, those of us, either pediatrics or pediatric surgeons who are scoping patients, enjoy them. The balloon, to make it short, has a life expectancy of about 6 months. And the principle is to put about 700 or 800 mLs of blue liquid into the balloon in the stomach so that the patient has the feeling of fullness. This is just a bridging technique. It gives you 6 months to talk to the patient, to work with the patient, and see whether he responds. If he is a no responder to the balloon, he will not be a responder to surgery. So the balloon has an interesting place, but it's not in the reach of any definite surgery. But working with the balloon in terms of patient selections, patient preparation is a nice thing to do.
Thank you, Professor Thiel.
Can I make another question? What about the pressure, CO2 pressure? I think that you need a lot of pressure for the abdominal cavity to have a space. And did you have any problem about embolism, something else, or about CO2? Okay.
Mm-hmm. Thanks for the technical details. First of all, putting the patient on the table is the first problem that you have. Let's start there. You need special tables. When putting the patient on the special table, you need special patterns on the table, padding, so that he doesn't get embolism during the operation. Air cushions and things like that. So you need to be equipped for that. Once you have adequate patient placement and adequate pattern, then it is no different to any laparoscopic surgery you do. You use a pressure of between 15 and 18. And again, the only really nice instrument that you need is a liver retractor. Remember, these livers are very, very heavy. They are juicy. They are dripping during the operation. So the Nathan hook that I used in the video, I think, is a very favorable instrument. No, the rest is not. It can be done. It should be done by us. Thank you.
Well then, if I may, as chairman, and to conclude, there is a trend for recurrence after several years with every operation. Could you comment on the possibility of redo surgery when any of those operations and the benefit of one or the other, as far as a redo is concerned 10 years later?
Mr. President, you saved the most difficult questions for the last question. Yeah, both techniques are different in terms of redo. Let me start with a topic that I should talk about, the sleeve. The sleeve has the advantage or the disadvantage that if the patient misuses it, it can regain volume, so it redilates. If it redilates, the effect is less. But the surgical approach is simple. You can re-sleeve it. You put it, again, you tailor it. The Roux-en-Y gastric bypass theoretically could be redone, but again, the aim of the Roux-en-Y gastric bypass, where the malabsorption takes place, is only that you postpone the common limb. So it's a very difficult surgery. While redoing the sleeve is very simple. Anybody who does fundoplications in our community is familiar with the upper GI tract and surgery.
Thank you very much for your answer.